Toronto Rehab is very pleased to present tonight's session on coping with chronic pain, tips and tools to help you manage your pain more effectively. It's part of our free public education program called Living With, Living Well. The program is designed to provide you with the latest research and up-to-date health information about a variety of topics related to rehabilitation and learning to live with or overcome the effects of injury, illness, or conditions associated with aging. Education is one of three core areas for Toronto Rehab. They are patient care through 7 clinical programs, research, and education. And Toronto Rehab has one of North America's largest rehabilitation research programs. I'm not sure if you know that. Last year, Toronto Rehab celebrated its 10th anniversary. As we have over the past 10 years, we will continue to evolve our patient care, research, and education programs, such as Living With, Living Well, to meet the growing demand for rehab services and technologies that result from an aging and growing population, medical advances, and a rise in the prevalence of chronic disease. Let me just give you an overview of the program tonight. Tonight's session has 2 parts. In the first part, you'll hear an overview of chronic pain from Dr. Andrea Ferland, and you'll be able to refer to information in your programs that were on your chairs. In the second part, you're going to hear from a panel of experts who will address chronic pain management from several perspectives. You will also have the opportunity to hear from 2 patients of the Rumsey Pain Center who will share their experiences and their successes. Now it's my pleasure to introduce our first speaker. Dr. Ferland is a physician with specialization in physical medicine and rehabilitation who graduated from Sao Paulo Medical School in Brazil and immigrated to Canada in 1997. Since then, she has completed her PhD at the University of Toronto and a 2-year clinical fellowship at Toronto Rehab. She's currently one of the physicians at the Toronto Rehab Musculoskeletal Program, where she attends patients with a variety of chronic pain problems, and works part-time at the Institute for Work and Health in Toronto, where she focuses on chronic pain issues. Additionally, she is a clinician scientist at the University of Toronto, and she's published more than 40 studies in various medical journals. Her most recent work involves working with a college of physicians of all provinces in Canada to develop, disseminate, and implement their clinical practice guidelines of opioids, am I saying that properly? Thank you, for chronic non-cancer pain. And she's participating in a project with U.S. National Institute of Health on a review of the scientific literature of acupuncture, massage, and spinal manipulation for neck and lower back pain. Please welcome Dr. Ferland.
Oh, these lights are really bright. Thank you, Patricia, for giving me this opportunity to be here tonight to talk to people, patients, public, about the problem of chronic pain. I can't see very well because these lights are really, really bright, but I'd like to ask you to raise your hand if you are here tonight, because if you have a chronic pain problem. Some people there. You see a lot of people are here because they have chronic pain problem. And if you are having pain right now, raise your hand. A lot of people. Okay, if you need to walk, to stand up, to go to the wall, that's normal. You don't need to be sitting the whole time, okay? If you're in pain or if you feel better standing up. This will be a very informal presentation. I tried to put together some information for you regarding the problem of chronic pain, how it affects. It's a very sad problem because it affects a lot of people and disrupts the lives of a lot of people. But we'll try to make this fun, interactive, and your participation is very important in this, okay? So, just find here the button. These are the objectives for my talk tonight. I have about 30 minutes to talk to you. I don't have, 2 hours. So I decided to talk to you about these objectives. First, to describe the difference between acute and chronic pain, to understand the various causes of chronic pain, to become conscious about the size of the problem in Canada and some possible solutions, and to learn how to talk to your healthcare professional when you have your pain. So in my talk, this 30 minutes, I'm not talking about treatments. We'll touch on the treatments and the various options for management of pain and treatment during the panel discussion. Is that okay? Are you okay with these objectives? So I brought here a picture that if you're in chronic pain, sometimes you may feel like this. It's sad, it's a sad situation, and I will read for you, this is a quote from a real patient. I'm constantly in agony, and I lost my job 6 years ago due to the performance issues. My doctor told me that I have fibromyalgia, but has been unable to explain the cause of my pain. And I feel my family has no patience with me now. Painkillers do nothing to help. Some days I can't get dressed. The pain is so bad. I feel that no one really understands. It's sad, and this was a quote from a patient in the UK. And they say the chief medical officer in UK last year put this report, and they say that over 5 million people in the UK are developing chronic pain every year. So what is pain? Why do we have pain? Why do we have to suffer pain? Pain is a normal thing of being humans or being animals. Animals have pain, humans have to be pain. Pain is unpleasant, and it has to be unpleasant. I'll try to explain to you why it has to be unpleasant. But it's an unpleasant sensory, emotional experience, and it may occur when there is a real lesion, or even without any lesion or damage to our body, it may have pain and suffering. So pain is an emotional experience, and it may happen even in the absence of tissue injury. That's the reason why it has to be unpleasant, because pain is the alarm system of our body. If it was not unpleasant, we would not seek help. If it was not unpleasant, we would not go and seek, a treatment. But that's true for acute pain. So imagine that pain is the alarm system of your house, of your body, and when some intruder is trying to enter your house, it has to go off, right? The problem is chronic pain doesn't serve that purpose anymore because there is no intrusion in your house, there is no lesion, there is no damage, and the alarm is going off all day long, 24 hours a day. Like right now, if you're having pain now and you are in chronic pain, there's nothing wrong to your body. Maybe some things are wrong, but maybe nothing because you have this pain for 17 years and you didn't die yet. So probably you don't have anything that is causing a tissue damage, but your brain is receiving information, pain, pain, pain. This is the alarm system is going off, 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 when nothing is wrong. And I will try to explain to you why this happens in our body. So this is a movie here, I think. Oops. How do I make this movie? This is to explain normal pain. So normal pain, you have an injury, for example, it will stick a needle in his finger. Everybody here did this, right? But the pain is an electrical impulse that will go throughout the nerves, the peripheral nerves, will go to the plexus. Here's the plexus, the brachial plexus. Will enter the spinal cord, and here in this region of the spinal cord, the dorsal horn, a lot of connections will be made up and down. These connections are very important because the dorsal horn is a place that a lot of modulation of pain can happen. So these are called synapses, these are called neuroplasticity. And this impulse, after it makes all these connections in the spinal cord, the dorsal horn, will go to the brain. We're going to see this going up to the brain. So the impulse is traveling up. What happens in the brain, it not only stimulates the sensory cortex, which is this one here. This is the sensory cortex where it tells you where exactly. You will know that it was this finger exactly here. This is a mapping of your body in the brain. But also, you will stimulate a lot of other areas of the brain stem, the spinal cord, and there can be a lot of modulation of this impulse. Modulation means the volume can be increased or it can be decreased. So I'll give an example of how the volume can be decreased. If this person has this pricking, the needle pricking his finger, but he is distracted, he's dancing, he's in a party, he's not going to notice the pain. This is a way of turning the volume of the pain down. So he's not going to pay attention. He's going to block the impulse, and there is nothing arriving here. In other situations, the volume can be turned up and increased. So a small impulse like that, like the needle pricking the finger, will arrive at the brain like a big bomb hitting the hand. So that's when the volume has been increased. What is the difference between nociceptive and neuropathic pain? Nociceptive pain is the normal pain. So that's the normal impulse that we saw traveling there, in the sense that the pain is felt normally. Everyone has this. There are some conditions, just for your curiosity, people that are born without feeling pain, these people, usually they die in their infancy because pain is protective. So the normal pain is called nociceptive pain. But neurological damage to our nerves, to spinal cord, to the brain, can cause what we call neuropathic pain. That's the abnormal pain, is when the alarm system of your house is broken. So it's going off, 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 off. What do? You call the firm that installed the alarm system in your house, say, come and fix it, it's broken. All my neighbors are complaining because of this noise all day long. When the alarm system of our body, the pain system, is broken, that's what happened, is neuropathic pain. So the good pain and the bad pain. The good pain is the normal pain, nociceptive pain, and the bad pain is the neuropathic pain. So the good pain is caused by a tissue injury. It's provoked by a stimulus. It responds to certain drugs like acetaminophen, the usual Tylenols, NSAIDs, non-steroidal anti-inflammatory drugs, steroids, muscle relaxant, opioids, acupuncture, massage, exercise, physical modalities, etc. Now the bad pain, when the alarm system is broken, it's caused by a nerve injury, but there's no tissue damage in terms of nothing wrong is happening with the skin or the tissues. It's a spontaneous kind of pain. May develop in days right after nerve injury. The day after a nerve injury, the pain may be there. It doesn't need to be chronic. And responds to different drugs. It responds to antidepressants, anticonvulsants, opioids, local anesthetics, and nerve blocks. What are the kinds of lesions that we can have in the nerve system that can cause neuropathic pain? In the central nerve system, we can have stroke, because it's a lesion in the brain. People who have stroke may have neuropathic pain after the stroke. Multiple sclerosis, tumor, spinal cord injury, anything that affects spinal cord may cause chronic pain. And lesions, these are much more common. Lesions in the peripheral nerve system, in the peripheral nerves. For example, post-surgery, sometimes I know people that they had low back pain, for example, and they went to have surgery, but the spine has a lot of nerves around the spine, and when the surgeon has to go into the spine, they cut a lot of nerves, and they may be creating neuropathic pain after the surgery. So the patient is left with a pain that is worse than the first pain that they had. Trauma or compression of the nerves, plexus injury, remember the plexus was here, the brachial plexus, the lumbar plexus, amputation, so the patient can have phantom limb pain, that's a kind of neuropathic pain, diabetic neuropathy, trigeminal neuralgia, postherpetic neuralgia, and these are just some examples. What are the signs and symptoms of neuropathic pain? So the kind of pain that people have when they have injury to the nerves are usually burning, cold, shooting, stabbing, shock-like, pins and needles occurring spontaneously or sometimes provoked by stimulus, sometimes just by touching the skin, which is a touch. If I touch my skin, my brain should be saying, someone is touching your skin. But in this case, a touch may cause pain. So again, that's the modulation of the pain. The volume is increased. Abnormal sensations, they may have tingling, prickling, itching, numbness, motor dysfunction, weaknesses of the muscles, incoordination of the muscles, abnormal posture, and also autonomic signs. If there was a peripheral nerve injury here, the whole arm may be swelling, changes in color, temperature, sweating. The nails may grow differently, and even the hairs of the skin, the arms or the legs may grow differently. So this is I put here a lot of information in this slide, and I'm trying to go slowly. How acute pain becomes chronic, okay? So people have an acute episode of pain. First question, did they have a nerve injury? Yes or no? In this case, no nerve injury, so it's nociceptive pain. Is this nociceptive pain every day? So an example of nociceptive pain that happens every day is people who have tendinitis, right? They're having, repetitive strain injuries, or they have tendinitis, or arthritis is a kind of nociceptive pain, and it's every day, every day, every day. Can this pain become chronic? Let's see. Sometimes no, the tendinitis is resolved and the person is happy, no more pain, pain resolved. But in some cases, it's a persistent nociceptive pain. So that's chronic nociceptive pain. And sometimes, we don't know why, but it might be genetic involved. The pain that is modulated, that nociceptive pain that happens every day, increases the volume of the message that is arriving in the brain. Pain is modulated, and also the patient had some predisposition, some psychological, some psychiatric diagnosis, stress, anxiety, depression, and they have chronic pain syndrome. But there's nothing wrong with the nerves. They don't have neuropathic pain. Now, if they have an acute neuropathic pain, they had a nerve injury, could be in periphery, spinal cord, or the brain, they have neuropathic pain. Neuropathic pain can be acute, become chronic, or not. It can resolve, in a few weeks, may resolve, and the patient is happy, or it can become chronic. Chronic neuropathic pain is really, really bad, because it's one of the worst kinds of pain. This person, this is a self-portrait of a person who had chronic neuropathic pain. I'll give a prize to someone in the audience that knows who she is. Oh, I have to give too many prizes. Frida Kahlo, right? You know what she had? What? Car accident. Yeah, do you know where she was born? Mexico. Oh my God, this audience is very knowledgeable. Wow. I presented this at Toronto Rehab a year ago, and I think in the audience there, the clinicians, only maybe I think 2 or 3 people knew all of these questions, so you're much better than they are. Frida Kahlo was born in Mexico. When she was 18 years old, she was involved in a car accident. She was in a bus. She broke, you name all the bones. She broke her spine. She didn't become paraplegic. She was able to walk after that, but she was in a wheelchair because of pain. But she broke her spine, pelvis, femur, foot, shoulder, clavicle. She underwent 35 surgeries. One of the surgeries, they put a rod in her spine to fix her spine, and they did this anteriorly through her abdomen, and they pierced her uterus, and she was unable to conceive. She got married to Diego Rivera at age 22, and he was a famous painter. He was a communist, and he was painting the murals in the Rockefeller Center in New York. Nobody knew that he was a communist, so that they allowed him to paint the murals. But she thought that she was a good painter too, just because she was married to Diego, but she was painting self-portraits. So if you see here, that's how I don't know if you can see well from the audience, but there are needles all over her body. She described her pain like a metal corset. She felt like a corset in her trunk, pressing her trunk and compressing her trunk 24 hours a day. And that was her dream, that someday she would be able to take out his imaginary corset that she was using and be happy again and use a nice dress. That's how she was. She spent months and months inside the hospital. That was her doctor, and she put a lot of hope in the treatments. He gave her tons of morphine. And at age 47, nobody knows exactly how she died, but it's believed that she did an overdose of morphine. And this is what she wrote in her diary a few days before she died. I hope the exit is joyful, and I hope never to come back. What is the prevalence of chronic pain in Canada? I brought here just a few examples. I couldn't, if I was going to bring here all the chronic pain types, this would be 20 slides. I brought the ones that are more common and we can understand and I can speak to you: arthritis, low back pain, and neuropathic pain. When I talk about arthritis, these are all the kinds of arthritis that I got in the Arthritis Society website. But I'm going to talk about osteoarthritis. What is the prevalence of osteoarthritis? You know that we have more than 100 joints in our body, and any of these joints can be affected by osteoarthritis. It affects any joint, but most commonly the ones that we carry weight. So the hips, the knees, ankles, spine, and this joint here, the first metacarpal, because we move the thumb all day long. So these are the most commonly affected joints. OA affects 3 million people in Canada. 1 in 10 Canadians suffers from chronic pain from arthritis. Affects men and women in equal numbers, and most people develop arthritis after the age of 45, but it can occur at any age. What about low back pain? Well, the causes of low back pain are many, but when we see a patient with low back pain, unfortunately, in 70% of the cases, we don't know where the cause is exactly. And we doctors have a nice name to say that we don't know, or stupidity in not knowing things. We call this idiopathic. And people call this, the common names are lumbar strain, lumbar sprains, non-specific low back pain, mechanical back pain. These are all names just to say that we don't know what's causing your low back pain. But in a few cases, we can point to a degeneration. This is osteoarthritis of the spine or herniated disc. This is an example of a herniated disc here. Osteoporosis fracture, spondylolisthesis. But in most of the cases, we don't know what causes low back pain. How often do you think is low back pain in the population? So if I have to ask you here, well, you are a biased population, right? Because you're here because most of you have pain. But if we go, to the population, the general population, oops, it's in another slide. How many people you think in the general population have low back pain today? Any guesses? What? 80%, that's a lot. Less. Okay, you'll see in two slides next, you're going to see. But one of the important things is that when a person has low back pain, it's important to rule out serious pathologies. You don't want to go on with your low back pain and you have a neurological condition that you can become paraplegic, or you have an infection, or a fracture, or a tumor, or inflammation. And when we want to remember, we call this NIFTI, N-I-F-T-I. That's a mnemonic to remember all these important things. This is the prevalence of low back pain. If we go and ask how many people have low back pain today, it's between 10 and 20% of the population, which means in Canada today, between 3 and 6 million people are having low back pain today. But this is not a problem because this low back pain, maybe because I was gardening yesterday, cleaning my backyard or cleaning my wardrobe, and today I have low back pain, but this low back pain will go away. That's not a big problem. The problem is this number here, chronic low back pain, affects between 5 and 8% of the population. People who have chronic low back pain every day. So if you have low back pain, I brought this booklet. I put 100 copies of this book outside for you. These are some hints and techniques and talking a little bit about treatments for acute low back pain. You go and pick your copy. What about neuropathic pain? How many people have neuropathic pain? In Canada, we don't have a populational survey, but they did this survey in the UK, and they found that neuropathic pain affects 7 to 8% of the population. This means that close to 2.5 million Canadians and 1 million in Ontario are affected by this kind of pain. And remember, that was the worst kind of pain that exists because it has all those components, pins and needles, burning. That was the pain that Frida Kahlo had. If we go to specific clinics, like if we go to the Toronto Rehabilitation Institute Lyndhurst Center, and you ask people who have spinal cord injury, 40% will have neuropathic pain. People who have stroke, between 1 and 6%. Amputees, 57%. Postherpetic neuralgia, 6 to 23. Multiple sclerosis, it may be 24%. There are some groups of people that are trying to help people with neuropathic pain. This is a website. It's here, actionontario.ca. It's a website put together for patients who have neuropathic pain to create awareness of the problem. I also recommend the Canadian Pain Coalition website. This is also a website put together for patients, by patients and healthcare professionals. It's called the Canadian Pain Coalition. They have a lot of resources. And every first week of November, they do a pain awareness week. I encourage you to go and visit this website and participate. What are some of our recommendations to improve the lives of millions of people? Well, training in chronic pain should be included in all medical schools, nursing, dentistry, occupational therapy, physiotherapy. Did you know that the veterinary medicine, they have 3 times more hours in training in pain than medicine or nursing. The animals are being treated much better than humans sometimes. Yeah? Consideration should be given to inclusion of the assessment in the primary care, assessment of pain and the disability in primary care. Also for patients in hospitals, the recommendation is that pain is assessed as one of the vital signs with blood pressure, pulse, temperature, etc. Another recommendation to improve the life of millions of people is to provide a network of rapid access to pain clinics where patients can be seen early and in an effective manner. I went to the Canadian Pain Society website 2 days ago just to count how many pain clinics are in Canada, and I counted how many there are in Ontario. 43 pain clinics in Ontario. And 2 of them were Toronto Rehab, the Ramsey Center and the Musculoskeletal Hillcrest Center. And also another recommendation is that a model of pain service or pathways of care should have clear standards and be developed by the experts. And I'm happy to say that the College of Physicians and Surgeons of Ontario and all the other colleges of Canada are putting together some guidelines for safe and effective use of opioids for chronic non-cancer pain. If you have any questions about this, I have the pleasure to introduce you Rhoda Reardon. She's the person at the college. She's here, Rhoda. She's here today, and she's the person at the College of Ontario who is responsible for creating these guidelines. You can ask her when this guideline will be ready, and when your physician can have access to these guidelines. Also, the Canadian Pain Society is putting together a lot of resources for patients, for physicians, guidelines for physicians, how to treat, how to manage, how to assess, how to diagnose, how to monitor chronic pain. And my last slide. When you go to a pain physician, what is the information that you have to bring? Remember the PQRST, double PQRST. I know you're not going to remember all of this. That's why I created a handout that I think all of you got it. So if you're going to see a healthcare professional, a physiotherapist, a physician, your family medicine, anyone, you want to talk about pain, you have to have this in mind. All of these questions, because these are the important questions that you have to bring for discussion. Thank you.